Okay, let's unpack this. We're tackling an exceptionally high-stakes topic today, flexible fiberoptic intubation, or FOI. And for those of you deep in the trenches preparing for your MD anesthesiology exams, especially curricula like Gujarat universities, this is, well, it's not just theory.
Not at all.
This is a core practical skill. It's the kind of thing that will form the cornerstone of your most challenging long answer questions and your Viva scenarios, too.
Absolutely. Our mission here is to give you that high-yield audio overview, structured exactly how examiners expect it.
With the precision and the clinical depth you're going to need.
Indeed. And we really can't overstate the importance of mastering this topic.
Yeah.
Fiberoptic intubation is it's a foundational technique in advanced airway management.
So when we say high yield, what does that really mean in this context?
It's high yield, not just because it's a device, but because to do it safely, you have to synthesize knowledge from everywhere. You need the pharmacology of topicalization and sedation. You need meticulous patient prep, the mechanics of the scope, and, flawless execution of the difficult airway algorithm.
So missing the nuances here means missing crucial marks.
Crucial marks, both in your theory papers and, frankly, in showing you're clinically ready in that Viva exam.
All right, let's establish a foundation then. When we talk about fiberoptic intubation, how are we defining it? And what exactly is the tool we're using?
Okay, so fiberoptic intubation, or FOI, we define it as the planned, controlled insertion of an endotracheal tube, an ETT, over a flexible guiding scope.
Right, so you can see the larynx and trachea indirectly.
Exactly, in real time. The primary tool, and you have to be ready to discuss this in depth, is the flexible intubation scope, or FIS.
Sometimes called the fiberoptic bronchoscope, or FOB.
They're used interchangeably, yes. And crucially, you should state that the FIS is the most widely used, most versatile, and frankly most trusted indirect laryngoscopy device we have.
You mentioned the flexible bronchoscope. That name implies it does more than just guide a tube. What's its broader clinical role?
That's a key distinction, a very good one. The examiner absolutely expects you to make it. While its role in intubation is paramount, especially in a difficult airway.
Whether the patient is awake or asleep.
Right. But the FOB is an indispensable tool across the hospital. In the OR, the ICU, the pulmonology clinic. It serves significant diagnostic and therapeutic functions.
Can you elaborate on those, the non-intubation roles?
Certainly.
Yeah.
So diagnostically, we use it for procedures like collecting specimens, bronchoalveolar, lavage BL. We use it to assess inhalation injury in burn patients, which helps guide when and how to intubate. And it's essential for finding the cause of a bronchial obstruction, a clot, a foreign body, anything.
And therapeutically?
Therapeutically, its value is in clearance. It's critical for suctioning massive amounts of secretions or, inhaled vomit, mucus plugs, blood clots, things that would otherwise cause atelectasis or hypoxemia.
So that multipurpose utility really elevates this discussion beyond just a simple intubation technique.
It really does.
Now, the sources consistently label FOI, specifically in an awake patient, as the gold standard for managing an anticipated difficult airway. Why does it hold that status? Why not just, say, use a video laryngoscope?
The gold standard question. That term is used because of the unparalleled safety margin it gives you in a high-risk scenario.
Okay.
The gold standard is, specifically, flexible scope intubation of the awake, cooperative, spontaneously ventilating patient. That full phrase is important.
So the moment you anticipate difficulty with both intubation and ventilation, this is your go-to.
That's it. The ASA difficult airway algorithm fundamentally stresses this approach because it maintains the patient's protective airway reflexes, it preserves pharyngeal muscle tone, and most crucially,
it maintains spontaneous ventilation.
SVA. If your first most controlled attempt fails, the patient is still breathing on their own. And that buys you precious, precious time.
That distinction, awake versus asleep, SVA maintained versus lost, that feels like the clinical and conceptual core of this whole topic.
It is.
So for the exam candidate listening, how does this usually translate into questions, written or Viva?
The patterns are very structured. For a long 20-mark essay, you can almost guarantee the focus will be on the meticulous preparation, the pharmacology, and the step-by-step technique for awake fiberoptic intubation.
Demanding a really detailed checklist-style answer.
A checklist approach, precisely. Shorter questions, maybe 5 or 10 marks or Viva scenarios. They'll test specific details. A list of indications, the exact Antisialagogue used and why, how to manage laryngospasm.
And increasingly comparing it to video laryngoscopy.
And direct comparisons to VL. You absolutely have to tailor your depths based on the marks.
Yeah, that's a perfect frame for what's ahead. Let's move from the why to the what, from the clinical rationale to the mechanics of the device itself.
Right. The fiberoptic bronchoscope, its basic principles.
Understanding the device is crucial for using it and for drawing those exam diagrams.
You absolutely must be prepared to draw, label, and explain each part of the FOB. It's conceptually divided into three main areas.
Okay.
First, you have the insertion cord. This is the long, flexible part that actually enters the patient. It's lubricated, usually 60 to 100 centimeters long, and it houses all the internal structures.
The image bundle, light bundle, all of that.
All of that, plus the angulation wires.
And as the other end, the proximal end.
That's the control section. This is the unit near the eyepiece where you, the operator, interface with it. It's got the eyepiece, a diopter ring for focusing, and most critically, the control lever.
The steering wheel.
The steering wheel, exactly. It lets you manipulate the distal tip's angle up and down, flexion and extension, via those internal angulation wires. If those are damaged, the scope's useless.
And the third major component, the one with the dual function.
That would be the working channel, or aspiration channel. It runs parallel to the fiber bundles inside the cord.
And its functionality is pretty vast, right?
Oh, it's huge. It allows for suctioning secretions, which is mandatory for your view. It lets you insufflate oxygen, which both helps with oxygenation, and can physically blow away secretions from the lens.
And as we'll get into, it's how you instill local anesthetic.
The spray-as-you-go technique. A crucial exam detail here is the downside. These narrow channels are notoriously difficult to clean and sterilize. That raises real concerns about cross-contamination.
Let's talk about the optics, the physics of how a flexible cord transmits a clear image. Examiners love to probe this.
They do. The core principle is total internal reflection. The scope is made of thousands of incredibly fine, flexible glass fibers, maybe 8 to 10 micrometers each.
Oh.
Very. And they're coated. When light enters one end at a shallow angle, it just can't escape the sides.
Oh.
It reflects internally along the whole length of the fiber and comes out the other end unchanged.
How are these thousands of fibers organized to actually create an image? What happens if one breaks?
Good question. They're in two separate bundles. The first is the light source bundle. It's an incoherent bundle.
Meaning the fibers are just randomly arranged.
Exactly. Their only job is to transmit bright light to the distal end to light everything up. The second is the image bundle. This one is coherent.
So every fiber has to be in the exact same position at both ends.
The exact same spatial relationship. This is what transmits the high-res image back to your eyepiece or a video chip. And if a single fiber in that coherent image bundle breaks,
You get a little black dot in your vision.
a fixed, small black dot. That's a key troubleshooting point to mention. If a light source fiber breaks, the image just gets dimmer.
That coherence principle is fascinating. Now, what about sizes and clinical relevance? We're not just dealing with one standard flexible scope, are we?
Not at all. And when you're picking an ETT, size matters a lot. Standard flexible scopes are usually good for ETTs of 6.0 millimeter internal diameter and up. You also have to know your working channel size. For instance, if you're doing a wire-guided intubation with a tube exchanger, you have to be sure it actually fits through the channel.
And the sources mention some specific rigid scopes, which can be confusing.
A common exam trap. You must differentiate the flexible intubation scope from specialized rigid devices that also use fiber optics.
Like the Bullard?
The Bullard Laryngoscope, for example, is S-shaped and rigid. It uses fiber optics for light and image guidance. More relevant for difficult intubation is the Bonfils retromolar fiberscope.
Which is more of a stylet.
It's a semi-rigid optical stylet, about 40 centimeters long with a fixed anterior curve. Its small size, maybe 5.0 millimeter diameter, lets you intubate around extreme angles. Understanding if a device is flexible or rigid is essential.
That detailed look at the equipment is a perfect setup. Now we get into the decision-making. The types of fiber optic intubation, how do we categorize them?
The choice really hinges entirely on the patient's risk profile and how difficult you expect it to be. The first and most important category is awake fiber optic intubation, AFOI.
And this isn't just a preference.
It's not a preference. It's considered the safest approach precisely when you anticipate both difficult mask ventilation and difficult intubation.
The cannot intubate, cannot ventilate scenario.
If you predict that, AFOI is your primary strategy.
What are the specific benefits of AFOI that make it so much better in those high-risk cases?
Its superiority is in preserving the patient's own mechanisms. By keeping them awake and spontaneously ventilating, you get 3 vital safety nets.
Good. What are they?
1, you maintain pharyngeal muscle tone, so the tongue doesn't collapse. 2, you maintain SVA, which buys you time and prevents hypoxia. And 3, crucially, you preserve protective airway reflexes.
Which guards against aspiration.
Exactly. A huge risk in trauma or emergency cases.
So conversely, when would a sleep fiber optic intubation be an appropriate choice? It sounds much riskier.
It is inherently riskier.
Yeah.
So a sleep FOI is only suitable if you anticipate a difficult intubation, but you expect mask ventilation to be easy.
Right.
It's an option for patients who just refuse AFOI, or maybe where you want minimal C-spine movement, but the patient is already unconscious.
But the caveat is huge.
Enormous. If you lose SVA and then can't intubate, you could very quickly get into a CICV scenario. Patient selection has to be meticulous.
And a quick note on pediatrics. AFOI seems like a non-starter there.
That's correct. AFOI is generally not a viable primary option in children. Lack of cooperation, ethical issues.
So what's the preferred method?
Pediatric anesthetists typically prefer an inhalation induction with something like sevoflurane. You ensure spontaneous ventilation is maintained throughout, then you use the scope once they're deep enough. The principle of maintaining SVA is constant, even if the technique is different.
Okay, so beyond awake versus asleep, we also have the choice of route. Oral versus nasal. What guides that decision?
It depends on anatomy and your clinical goals. Nasal FOI is often, believe it or not, technically easier for the operator.
How so?
The nasal passage acts like a natural guide. It forces the scope to stay midline, and the tip usually points right at the glottis as it enters the oropharynx. And critically, it's the preferred method when mouth opening is severely limited.
Trismus, mandibular fractures, that kind of thing.
Exactly. Cases where you couldn't even get the scope in orally.
The oral approach, oral FOI, seems a bit more complex then. It needs special adjuncts.
It's significantly more challenging. The scope can get caught up on the tongue or cheek, and it's much harder to stay midline. This is why you need auxiliary devices.
And for the exam, you need to name them.
You must. The Ovasadian fiber optic intubating airway is the classic one, the Williams airway, the Berman airway. They all serve a triple function: keep the mouth open, act as a bite block to protect the scope, and guide the scope midline past the tongue.
This brings us to the clinical cornerstone, the indications for fiber optic intubation. You said this is a very high-yield area.
Absolutely. Memorizing this list is non-negotiable. The number one overarching indication is the anticipated difficult airway.
Where awake FSI is the gold standard.
The gold standard. But the examiner wants specific examples. Pathologies.
All right, give us the specifics that mandate this technique.
First, limited mouth opening. Any condition restricting the interincisor gap below about 2.5 centimeters pushes you towards FOI.
Even if a slim video laryngoscope might fit.
It might down to maybe 1.5 centimeters, but FOI is far more reliable, especially the nasal route, which bypasses the mouth completely. Think severe trismus, TMJ disease.
Okay, what's next?
Second, and this is the classic textbook indication, is cervical spine instability. FOI is the technique of choice when you can't or shouldn't extend the neck.
So unstable C-spine fractures, ankylosing spondylitis.
Exactly. Ankylosing spondylitis, the bamboo spine, is a perfect example. Or severe rheumatoid arthritis. AFOI is preferred because it guarantees minimal neck movement, and you can monitor the patient's neurostatus throughout.
And the third?
Third is facial or airway trauma. When the anatomy is so distorted from swelling or hematoma that you can't recognize landmarks directly, but, and you must cite this caution, navigating an airway full of blood and secretions is extremely challenging, even for experts. It's a frequent cause of failure.
What if the standard attempt at intubation has already failed?
That's your fourth point. Failed direct laryngoscopy. As long as you can still ventilate the patient with a mask or an SGA, and a sleep FOI is a recognized alternative within the difficult airway algorithm.
Before you go to something invasive.
Right. And fifth, that critical group of awake intubation scenarios. These are cases where preserving SVA and reflexes isn't optional, it's essential for survival.
The full stomach patient.
The classic full stomach, non-facet emergencies, pregnancy, severe GERD, trauma, and patients with severe hemodynamic instability, where the stress of a rapid induction is just too dangerous. AFOI manages the airway while keeping them stable.
That's a very complete picture of the clinical need, but safety also means knowing the boundaries. Let's talk contraindications and limitations. When do we not use the FOB?
Knowing when to stop demonstrates real clinical judgment. The limitations fall into about 4 categories. The first and most common operational barrier is the uncooperative patient.
An absolute relative contraindication.
Exactly. If a patient is agitated, combative, altered common in the ICU, or ER, AFOI is very likely to fail. You can't get the cooperation, and you can't apply the topical anesthesia you need.
What about the airway environment itself?
Massive airway bleeding or secretions. This is cited as the single most common reason for FOI failure, period.
Because you just can't see.
The scope is useless if you can't see. We have some troubleshooting tricks, but if there's a lot of blood, the procedure will fail, and you have to move on immediately.
And total airway collapse.
If you encounter a complete airway obstruction, FOI is absolutely contraindicated. Remember, FOI is for a patent airway that's difficult to intubate. If it's completely obstructed and you can't ventilate, you move to an immediate surgical airway, a cricothyrotomy. Using the FOB here is just wasting critical time.
And finally, a limitation trainees often overlook.
Resources and expertise. You need a skilled, calm operator. This is not a technique to be attempted by a novice in an emergency. And you need the equipment, the scope, light source, everything to be functional and ready.
This brings us right to the heart of that 20-mark essay, preparation for awake fiberoptic intubation. The clinical checklist.
Meticulous structured preparation is probably 90% of a successful AFOI. And it starts long before the patient even enters the room.
With counseling.
First, patient counseling and consent. This is mandatory. You have to psychologically prepare the patient, explain why they need to be awake, what they'll feel. Explicit, informed consent for AFOI must be obtained and documented.
Okay, they're consented. What about monitoring and positioning?
Standard ASA monitoring is non-negotiable. Pulse oximetry, NIP, ECG. And here's a critical exam detail. Continuous ETCO2 monitoring is often unreliable during AFOI.
Why is that?
Because the scope creates a significant air leak, especially in the nose. So expired gases escape around the scope instead of going through the sampling line.
Got it. And positioning.
We maximize the airway geometry. If the C-spine is stable, the classic sniffing position. For obese patients, the ramp position is essential, using blankets to align the ear with the sternal notch. A slight head-up position, maybe 20-30 degrees, is also often used to reduce aspiration risk.
Let's shift to the pharmacology, starting with the crucial role of antisialagogues.
Secretions are the enemy of visualization, so antisialagogues are absolutely imperative. The drug of choice is routinely glycopyrrolate.
And you need to explain why.
You must. It's preferred over atropine because it's non-sedative, has fewer CNS side effects, and causes less tachycardia. And timing is crucial. Give it intravenously at least 15 to 20 minutes before you start topicalizing to let it work.
And the safety net, oxygen supplementation.
Pre-oxygenate with 100% O2, of course. But you need to provide supplemental O2 throughout the entire procedure. You can use nasal prongs, and for a higher scoring answer, you should mention this. You can actively insufflate oxygen through the FOB suction port. This also helps blow secretions away from the tip. And you must mention THRV.
Transnasal high-flow rapid insufflation ventilatory exchange. It's a more modern concept.
It is, and mentioning it shows you're up to date. DHRV uses high flows of oxygen, 50-70 liters per minute. This flushes the pharyngeal dead space, allowing for true apneic oxygenation. It dramatically increases the patient's safe apnea time. It's the ultimate safety measure.
Okay, finally, the meticulous equipment preparation checklist for FOI.
Your difficult airway cart needs to be tailored. You want long, armored ETTs, the wire-reinforced ones that resist kinking.
And you check the cuff?
Always check the cuff. And remember, if you use a stylet, it needs to be straight, not hockey stick shaped. Check the FOB itself, light, angulation, suction. And the golden rule, have your alternative devices ready to go. VL and intubating LMA, suction, and the emergency surgical airway kit, physically marked.
That attention to detail is key. This prep leads us right into airway anesthesia and sedation, another very high-yield area.
It is. The goal is total anesthesia of the airway, from the nasopharynx to the trachea, with minimal systemic absorption, all while maintaining SVA.
And the drug of choice is lidocaine.
Lidocaine. For its rapid onset and high therapeutic index, we use it via multiple methods of airway topicalization.
So how do we tackle the upper airway?
We start broadly. You can use 4% lidocaine via nebulization, or lidocaine gargles, to anesthetize the pharynx and epiglottis.
What about for deeper, more localized anesthesia?
For that, you can supplement with specific regional blocks. Bilateral superior laryngeal nerve blocks for the mucosa above the cords, and transtracheal blocks for the mucosa below the cords.
But these blocks have risks, right? That's a key exam point.
Absolutely. You must mention the potential for nerve or vessel injury or local anesthetic systemic toxicity last.
Moving distally, there's the spray-as-you-go technique.
Correct. This is the cornerstone for the lower airway. As the scope passes the epiglottis, you inject small aliquots of lidocaine through the working channel. You do it just above the cords and then again once you're in the trachea. It's very precise.
And nasal FOI has that unique requirement of managing the blood vessels.
Yes. Nasal topicalization is critical because the nasal mucosa is so vascular. Vasoconstriction is crucial to prevent bleeding.
So you use a vasoconstrictor with the local anesthetic.
Exactly. Use 2% lignocaine jelly plus vasoconstrictor-soaked pellets, phenylephrine, or adrenaline. A specific mixture to mention is lidocaine 3% and phenylephrine 0.25%, a great alternative to topical cocaine.
A quick high-yield check. The risk associated with certain topical sprays.
Yes, the examiner will probe this. You must mention the risk of methemoglobinemia with agents like benzocaine or Sedation. It's a life-threatening complication that requires immediate recognition and treatment.
Okay, let's talk sedation. It's a tightrope walk.
It is. The goal is light sedation, Ramsey scale 2 or 3. You want them calm and cooperative. We use short-acting agents like midazolam and fentanyl. Propofol infusions or small boluses can also work well.
But modern practice really favors one agent in particular.
Absolutely. Dexmedetomidine is the preferred agent. It's the selective alpha-2 agonist that gives you this ideal profile: sedation, analgesia, some amnesia, and antisialagogue properties.
All while maintaining spontaneous respiration.
That's the unique feature. It maintains a state of cooperative sedation with minimal respiratory depression. Patients can still respond to you, but they tolerate the procedure beautifully.
Which makes maintaining spontaneous ventilation, or SVA, the single most important safety rule of AFOI.
It is the absolute safeguard. If you fail to intubate, the patient is still breathing. Losing SVA is a clinical disaster in a difficult airway patient. It's the one thing you must prevent.
Okay, preparation is complete. Let's walk through the mechanics. The technique of fiberoptic intubation.
We can start with the stepwise oral fiberoptic intubation. Step 1 is preparation. The ETT is preloaded onto the lubricated FOB. You insert an oral airway, like an Ovasapien, to keep the mouth open and guide the scope midline.
Step 2?
Step 2 is advancement. You guide the scope past the tongue, visualizing the landmarks: epiglottis, glottis, vocal cords. Step 3 is tracheal entry. You advance the scope through the cords into the trachea.
And then, the riskiest part, railroading the tube.
Step 4, railroading the ETT. Once the scope is deep in the mid-trachea, you advance the ETT over it. And this is the single most important limitation of FOI. This step is a blind technique at the laryngeal inlet.
So the tube can get caught.
It can impinge against the anterior commissure or the arytenoids. This can cause trauma or prevent you from placing the tube at all.
Okay, now for the alternative. Stepwise nasal fiberoptic intubation.
The steps are similar. Preparation. After vasoconstriction, you place the ETT into the nasopharynx with the tip just above the glottis. Scope insertion. You pass the FOB through the ETT and guide it into the trachea.
And it tends to stay midline more easily.
Much more easily. Then you visualize and railroad, just like before. The final railroading step is still blind and still carries that risk of laryngeal trauma.
What are the vital airway landmarks you have to confirm visually?
You must be able to recognize them in the supraglottic area: the epiglottis, the arytenoids, the vocal folds. Once you're in the trachea, you need to see the cartilaginous tracheal rings and, distally, the carina, the bifurcation point. Confirming these ensures you're not in the esophagus.
And finally, confirming ETT placement. How is the FOB used for this?
Visual confirmation with the FOB is the primary gold standard method. You advance the FOB through the ETT and confirm the tip is about 3 centimeters or 4 to 5 tracheal rings above the carina.
That specific distance is important.
Very. It minimizes the risk of right main stem intubation. Then, of course, you do your secondary confirmation with auscultation and continuous ETCO2.
We've covered the ideal scenario, but things can go wrong. Let's move to complications and troubleshooting.
You have to know these cold. The most immediate threat is hypoxia. It can happen fast if the procedure is long or if you lose SVA. Prevention is all about continuous oxygen and maintaining that SVA.
What about the patient's reflexes, like coughing and laryngospasm?
Those are triggered by inadequate topical anesthesia or mechanical irritation. If there's severe coughing, you deepen the sedation with a bolus of propofol.
And if it's a full-blown laryngospasm?
If it's a severe laryngospasm and it's unresponsive, you have to be ready to give a small dose of muscle relaxant, like succinylcholine, 10 to 20 milligrams, to break the spasm. And you should mention the risk of negative pressure pulmonary edema here.
Bleeding is another constant threat, especially with the nasal route.
Yes, and it's a failure risk.
Right.
It's best prevented with good vasoconstriction. If it happens, you need immediate focused suctioning. If it's massive, you might have to abandon the attempt.
What about the most common technical problem? Failure to advance the tube. The railroading failure.
Impingement. It happens all the time because the tube's bevel catches on the arytenoids or the anterior commissure. We have a few troubleshooting steps.
Okay.
First, if your view is obscured by secretions, try insufflating oxygen through the working channel to blow them away.
And if the tube itself is stuck?
If you have tube impingement, try external laryngeal manipulation, or ELM. Gently press on the larynx to change the angle. You can also slightly rotate the tube, usually anti-clockwise, to guide the bevel past the obstruction.
And if that doesn't work?
The definitive salvage is the wire-guided technique. You pass a guide wire through the FOB's working channel into the trachea, then you remove the FOB over the wire, and finally advance the ETT over that fixed guide wire. It turns a blind strip into a controlled one.
Now let's contextualize all this within the bigger picture. The role of fiberoptic intubation in difficult airway algorithms.
Right. AFOI is the explicit foundation of the awake intubation arm of the ASA algorithm. It's what you do when you predict difficulty before you induce anesthesia. It's a preemptive step, not a rescue.
And how does video laryngoscopy compare to FOI within that algorithm today?
VL is now an essential component, especially for rescue or anticipated difficulty under GA. But FOI remains superior in certain highly specific situations.
Such as
severe cervical spine immobility and extremely limited mouth opening. A slim, flexible scope can go where even a thin VL blade can't. VL usually requires muscle relaxation, sacrificing SVA, whereas AFOI maintains that safety net.
Okay, worst case scenario. We've meticulously prepared, but FOI fails. What are the mandatory backup plans?
If awake FOI fails, but the patient is still cooperative and breathing, you can try an alternative awake technique. Or if it's not an emergency, you postpone the case.
And if it becomes an emergency, if you get to a cannot intubate, cannot ventilate scenario?
In that crisis, you need immediate recourse to an invasive airway. That means an emergency surgical cricothyrotomy, or using an intubating LMA as a rescue device. Being ready to transition to an invasive airway is the final safety decision.
This is a perfect lead-in to our exam synthesis. Let's start with comparison with other airway techniques, FOI versus VL.
Okay, the key trade-offs. The primary FOI advantage is its utility in anatomical distortion and its ability to maintain SVA when awake. The primary VL advantage is continuous visualization. The larynx is in view the entire time.
Which completely eliminates that blind railroading step.
Exactly. It reduces the risk of laryngeal injury and often makes VL faster than FOI.
And the comparison with traditional direct laryngoscopy, or DL.
DL is fast and effective, so it's preferred for the unconscious apneic patient. But FOI is safer and more controlled, it requires less force, is safer for the C-spine, and avoids dental trauma.
So for the exam, what are the key comparison points to hit?
Two things. First, cervical spine movement. Minimal with FOI. Significant with DL, even with manual inline stabilization. And Mills itself makes the view harder. Second, the full stomach scenario. AFOI is by far the safest elective choice compared to a rapid sequence induction for DL or VL.
Let's move to the insider info, Viva points and common exam traps. What are the questions examiners love to ask?
They want immediate confident answers to definitional questions. You need to know these cold. Like, define the gold standard for difficult airway. The full answer is, awake fiberoptic intubation in a spontaneously breathing patient. Or, which Antisialagogue do you use and why? Glycopyrrolate, because it's non-sedative.
What's the risk of using benzocaine?
Mismeglobnemia. What's the difference between FOI and VL railroading? VL is visualized, FOI is blind. And what is the required ETT tip position? 3 centimeters above the carina.
What are the common student mistakes that reveal they're not fully prepared?
The mistakes reveal a lack of clinical judgment. Top of the list. Over-sedating the patient and losing spontaneous ventilation is a functional disaster. Failing to prepare the nasal passage with vasoconstrictors, which leads to bleeding and failure. And failing to have backup plans physically ready to go. Examiners will ask about that.
And the safest way to answer?
Your answer should always return to 3 principles: patient safety, meticulous preparation, and maintaining spontaneous ventilation. Demonstrate that you understand the ASA algorithm structure.
Okay, let's make sure the written paper is covered. Diagrams and exam presentation, how to structure that huge 20-mark answer.
For any descriptive question, a well-labeled fiberoptic bronchoscope diagram is critical. You must accurately draw and label the components: insertion cord, control lever, working channel, eyepiece, light bundles. It proves you understand the mechanics.
And the visualization component.
You should be prepared to list and describe the airway anatomy landmarks as seen on bronchoscopy, the sequence: epiglottis, vocal folds, arytenoids, then the tracheal rings, the carina, and the bronchial bifurcations. It shows you know what success looks like.
Finally, let's give our listeners a model structure for that 20-mark answer.
Okay, a high-scoring structure needs a logical flow. 1. Introduction and definition. Define FOI. Establish it as the gold standard.
2. Basic principles of the FOB.
With a quick labeled diagram. 3. Detailed indications. A bulleted list. 4. Meticulous preparation. There's a big section. Counseling, positioning, drugs, oxygenation. 5. Airway anesthesia and sedation. Detail the methods in your drug choices, especially dexmedetomidine and the need to maintain SVA. 6. The technique, stepwise, oral and nasal.
Highlighting the risks.
Highlighting the blind railroading step. 7. Complications and troubleshooting. And finally, 8. Conclusion. Place AFOI definitively within the ASA algorithm.
That structure is perfect for capturing every possible mark. Now for our final summary, the rapid-fire recap designed to stick.
Let's run through the high-yield bullet point recap. Commit these 12 facts to memory. 1. AFOI preserves SVA and reflexes. It's the gold standard.
2.
2. Glycopyrrolate is the mandatory antisialagogue. 3. Dexmedetomidine is the advantageous sedative choice because it maintains respiration. 4. Nasal approach requires meticulous vasoconstriction.
5.
Key indications are limited mouth opening, unstable C-spine, high aspiration risk. 6. Key limitations are secretions, blood, and an uncooperative patient. 7. Railroading is a blind step risking laryngeal injury. 8. Video laryngoscopy offers continuous visualization, mitigating that blind step. 9. ETT tip placement is confirmed visually, 3 centimeters above the carina. 10. Complete airway obstruction requires a surgical approach, not FOI.
11.
11. Benzocaine carries a risk of methemoglobinemia. And 12. If AFOI fails and you lose mask ventilation, move immediately to a rescue invasive airway.
And the final word, a model conclusion paragraph to wrap up that essay with maximum impact.
Fiberoptic intubation remains a fundamental and mandatory skill in modern anesthesia practice. It provides the safest, most controlled means of securing the airway in complex, high-risk scenarios, particularly where maintaining spontaneous ventilation is essential. Optimal outcomes depend entirely on thorough pre-procedural planning, meticulous application of topical anesthesia, and strict adherence to the difficult airway algorithm, cementing its place as the definitive technique for anticipated difficulty.
So what does this all mean for the future anesthetist? We've talked about how video laryngoscopy has mitigated some of the risks of FOI, especially that blind railroading step, and it's often faster. But FOI still holds its ground in severe anatomical constraints, like extreme C-spine immobility or severely limited mouth opening. So the question is, will FOI always maintain its formal gold standard status in the face of these rapid digital advances?
Or will training eventually shift away from flexible scopes towards advanced digital visualization?
Exactly. What are the implications for the next generation of anesthetists if they become overly reliant on digital views and fail to master that tactile, flexible scope skill?
That's something to mull over as you commit this comprehensive, high-yield checklist to memory.
Good luck with your revision.